So I am demonstrating phacoemulsification in a case of primary angle closure. As you can see, the anterior chamber depth is extremely shallow and it's fairly hard cataract. This is the Scheimpflug image showing a shallow anterior chamber. We can see just 1.87 millimeter depth internally and chamber angle 20 degrees. This is the surgical microscope view of the case. Now this is a 2.2 millimeter incision, injecting some dispersive viscoelastic and then using soft shell technique putting cohesive viscoelastic below that. 2 side ports are made. And this soft shell technique is extremely important in these shallow eyes because otherwise it becomes very difficult to do a continuous curvilinear capsular rhexis. And now with some amount of space in the anterior chamber, the rhexis is initiated and propagated. You can see in spite of the cohesive viscoelastic, it's not easy to manipulate the cystitome. Cystitome is the best choice in such eyes because a capsular rhexis forceps is generally bulky. The rhexis has been completed and now some amount of the cohesive viscoelastic is burped out and a hydrodissection is done. A good fluid wave is seen and nucleus rotation is complete. Now again putting in dispersive and cohesive for the soft shell technique before phaco. Now this is the purple tip of the Bausch & Lomb Stellaris machine going through a 2.2 millimeter incision. This is a very good flared tip and it works well for hard cataracts. Along with the Siebel chopper I am using, I'm going to be doing the vertical chop technique. Now this is the first chop which has successfully been completed, and the aim here is to make multiple small pieces. So as you can see, I'm making very small nuclear fragments. And now once about 7 to 8 nuclear fragments have been done, you see how easily each of these fragments has got out to the iris plane and can be emulsified very easily. So this was a moderately dense cataract, about grade 3, but a good vertical chop has ensured that it's easily emulsified. And that completes the phacoemulsification. Now once phacoemulsification is done, the rest of the surgery is quite easy in these cases. Now once the cortex is aspirated, it's time for IOL implantation. I had done a 2.2 millimeter, but as you can see, I'm extending the wound slightly, and this is a large lens. This is a Alcon 30 diopter Clarion lens, and I like to use the Monarch 4 injector, which is a screw type injector, which allows a much more controlled delivery of this large and bulky lens. You can see it goes very smoothly into the capsular bag, and rather than a push type injector which causes a sudden jerk, screw type injector works much better. And now the viscoelastic is removed, and I do a very gentle hydration of the wounds here because these patients can have malignant glaucoma develop, so very gentle hydration of the side ports and slight amount of irrigation of the main wound as well. Now I just use 2 cotton buds to make sure that the side ports are well sealed, and that completes the case. This is post-op day 1. You can see we've got a very clear cornea even though the chamber was very shallow, and now the chamber has become fairly deep and you can see a good red glow which indicates good corneal clarity. Thank you for watching.